We'll now begin with the observation portion of the physical exam. We'll look at Lee's lumbar lordosis, and what we're looking at here is a normal lumbar lordosis. And when you do the when you're performing the observation part of the exam, you're looking for obvious deformities. If the deformity is not obvious, then it's not relevant. So a common deformity on back exam is a shift. You quite often see this particularly in acute mechanical back pain. The other is a kyphotic deformity where the patient has a flattened or rounded lumbar lordosis. These are two of the commonest deformities that you see in acute mechanical back pain. And just back to the normal lordosis. There you go. And there's a normal lumbar lordosis. Next, we'll look at range of motion. I'll just get you to turn this way. I'll get Lee to demonstrate normal lumbar flexion and extension. So go forward for me and touch your toes. So there's the normal lumbar flexion. And just to review that quickly, we're looking at the flow or the rhythm. So he has normal lumbar or lumbopelvic rhythm. There's the first about 45 degrees of flexion is at the lumbar spine, and then the hips rotate. Now we'll look at lumbar extension. Put your hands on your hips and bend right up here. Yeah, right there. Good. And backwards. Good. And that's normal lumbar extension. Turn this way for me just a little bit. Good. Okay. Now what we'll look at is a couple of common altered lumbopelvic rhythms. And the first and probably the commonest, just put your hands by your sides, is as they bend forward, the patient is almost like they're bending around a post, and they can't quite bend all the way, and then they come back up like that. So just do that one more time for me. So they tip over to the side like they're bending around a post, and then they come back up and around, and that's their attempt to stay off the sore spot. Now another common alteration of the normal lumbopelvic rhythm is their back is quite flat. So there's no bend in the lumbar spine at all. And that's all at the hips. And for lumbar extension, the commonest alteration in normal rhythm that you see is that they just can't bend backwards. Put your hands on your hips, and it's like running into a block. They bend back a touch and they can't do anything after that. The other common one is hand walking up the thighs, or Gower's sign. So as they bend forward, they use their hands to support their thighs. Okay, and come on back up. And they cheat by squatting to get themselves back up to an erect position. The next test we're going to do is the Trendelenburg test, and that's a test of hip abductor power, and that's an L5 innervated muscle. And you start from a position behind the patient, and you look at their PSIS, their posterior iliac spines. These are the dimples of Venus. You put your thumbs right on those, and I'm going to get you to stand on your right foot for me. And as he steps up, this leg or this hip lifts up a touch. Good. Back down. And I'm looking for my thumbs, and you can see that thumb rises up relative to the other one, about 30 degrees. Good. Back down. As long as it's symmetrical is a normal test. So whether the thumbs stay parallel or one rises up and the other rises up, as long as they're symmetrical, that's a normal result. If one drops down or one stays even and the other rises up, that's an asymmetrical test, and that indicates weakness in the hip abductors. The other thing to remember is that the side you're standing on, so stand on your right foot, I'm testing these hip abductors. So that's the femur abducting or the pelvis abducting on the femur. Good. The next test we're going to do is the test of plantar flexion. So I'm going to get you to turn around for me. And to do a manual muscle test of plantar flexion with resisted hand resistance is very hard to do because it's a very powerful muscle, so you're better off using their body weight as resistance. So I'm going to get Lee to stand on his right foot. Make sure you keep your knees straight, and I want you to rise up on your tiptoes. And I'm just feeling here. Good. Back down 5 times. 2, So I'm looking to make sure that he can get that heel up, that he's able to, he doesn't have to push through my hands a whole lot other than for balance. And once he's done 5, I'll get him to switch to the other side. And up. So he needs to keep his knees straight and he's rising up on his toes. And again, I'm looking for a symmetrical test. Can he do the same number of repetitions? Does he have to push into my hands a whole lot because he's trying to compensate for weakness in the muscle, or he may not be able to plantar flex at all. Okay, next we'll look at 2 tests of simulation and standing. So the first is the axial load. So normally when I'm doing a history and a physical exam, I don't prompt or lead the patient. But in these particular tests, I'm going to lead the patient or ask them a leading question. I'm going to ask them, does this cause you back pain? So what I'm going to get you to do, Lee, is I'm going to get you to stand facing away from me. And I'm going to put my hands on top of your head and I'm going to compress your spine. I'm going to press through the top of your head and I'm going to compress your spine. And I want to know if that causes you back pain. When I do this test, I'm going to push through his head, not very hard, but I'm also going to squeeze his shoulders. And and I'm going to make a bit of a noise. I'm going to, and that indicates to the patient that I'm working hard, but in essence what I'm doing is I'm trying to see if he's has a heightened pain response, because normally in people even with acute back pain, pushing down like this won't cause any back pain. But if they have a heightened pain response, they may crumple, their knees may bend, or they may grab their back and verbalize regarding, grimace and verbalize regarding pain. The next test of simulation is the acetabular rotation test. And again, I will ask the patient a leading question. I'll say, could you put your feet right together for me? It's important that the feet are right together. And then I will put their arms down by their hips and I'll grab a hold of them. And what I will do is I'll tell the patient that I'm going to twist their spine and I want to know if this causes them back pain. So Lee, I'm going to twist your spine. And the first 30 degrees of rotation in either direction actually happens at the hip joints, at the acetabulum. There's no movement at the lumbar spine. And so any complaint of back pain in this range of motion is likely due to a heightened pain response or anticipation of pain or fear of pain if they're complaining of back pain. And the next test we're going to do is we're going to do test the ankle jerks or the ankle reflexes, which is an S1 innervated reflex. And the best way to do this is to have the patient kneel on a chair. And what I will have them do is I'll have them squeeze the back of the chair with their hands, because that's a reinforcement, or the Jendrassic maneuver. What it does is it puts their concentration on their hands and allows their ankle muscles to relax. So while they're relaxed here, I'll give his ankle a little wiggle and I'll just hit the back of the Achilles tendon and you'll see it jump. And again, there you go. And that's symmetrical. So the reflex is present and it's symmetrical, and that's a normal test. In an abnormal test, I might tap like this and then there's nothing on that one. So these are not symmetrical, and that would indicate loss of the ankle jerk reflex. The next part of the physical exam that we'll run through is the physical test done in sitting. And the first one that we'll test is extensor hallucis longus, or big toe extension, which is an L5 innervated muscle. And what I'll get is the patient to have a seat, and I'll have them with their feet on the floor, and I'll have them extend their toes. And what I'm going to do is I'm going to put my thumbs right along the tops of the toes. If you're on the top of the toe, you're going to bend it at the IP joint, and you need to be right down on top of the entire length of the big toe. And I'm going to push down at the same time. And I'll get an idea of his muscle strength. And again, I'm looking for a symmetrical result. Now, true neurological weakness is a smooth letting go of the muscle. So if I have his toes up, and then one will let go quite smoothly. Now, if the patient has a heightened pain response or is not giving full effort for whatever reason, one of two things will happen. The first is that they just drop. So as I'm there, he'll drop like that, and that's not neurological weakness. The second may be a type of cogwheeling where they let go and they drop in a staged manner like that. And again, in a person that's otherwise normal apart from mechanical back pain, you wouldn't see cogwheeling like that. So that's indicative of heightened pain response, or they're not giving full effort for whatever reason. So the next test we'll do is ankle dorsiflexion, which is an L4-5 innervated muscle. So I'll have the patient pick their feet up like that, and I'm just going to put my hands on top of their feet, and I can push down. Now this is a fairly powerful muscle, so quite often I'm going to have to put both hands on top of one in order to defeat his muscle strength. And again, I'm looking to see if it's symmetrical. And again, true neurological weakness is a smooth letting go. If they're not giving full effort for whatever reason, or they have a heightened pain response, they'll just drop, or they'll be cogwheeling like that. And that's ankle dorsiflexion. Next is toe flexion, and toe flexion is a test of the S1 innervated muscles. And so I'll have them bend their toes in like that, and I'm going to pull up, good, and then I'm going to pull up, good. And again, we're looking for symmetrical strength, and if there's true neurological weakness, there'll be a smooth letting go of the toes on one side, which is indicative of weakness of that S1 muscle. Next, we'll have Lee come and sit up on top of the bed here. And the first test they'll do here, sitting up on the exam bed, is a test of the the knee jerk reflexes. And this is an L4 innervated reflex. And in order to find the knee jerk reflexes, I'll put my thumb on his patella, and I'll just let it slide down until I'll come off the tip of the patella, off the inferior pole, and I'll end up on the patellar ligament. And I can keep my thumb there and tap it, or I can just tap it like that. So same thing, drop down, there it is. And if I'm having trouble getting the reflexes, I can have him do a Gendrasic or a reinforcement maneuver. So if you can grab your hands, look up at the ceiling and pull on your hands, and that will put their mind on their hands rather than what you're doing down here, and quite often it'll bring their reflexes out. And again, we're looking for a symmetrical response. The reflexes should be the same on both sides. They could be mute, or they could be, neither would be present on either side, or they should jump the same amount on either side. If one is present like that and the other there's nothing or very little, then that would be considered this reflex is normal and this one is reduced or absent, and that would be indicative, or could be indicative, of a problem. When it comes to the neurological exam, motor power loss, especially recent motor power loss, is the most important of the hard neurological findings, followed by reflexes, followed by sensory testing. And if you have a person that has mechanical back pain and their neurological exam is completely normal except for a reduced or absent reflex, that finding is irrelevant. You don't have to worry about it. Next, we'll test his plantar's response, which is a test for pathological reflexes. You're looking for problems higher up in the spinal cord or the brain. Rarely problems in the spinal cord or brain can masquerade as back pain, and this helps eliminate those problems. Multiple sclerosis, spinal cord tumors, things like that. This simple test will pick those problems up. And what I do is I lift the patient's foot up like this, and I'm going to use the fairly sharp end of a reflex hammer to scrape the bottom of his foot. You have to scrape quite hard, and you do this in a J-stroke manner. And what you're looking for is his toes will curl in a bit. They curl in like that, and that's a normal response. An abnormal response would be the big toe extends and the toes fan apart like that. And again, you're looking for a symmetrical response. You can scrape that foot and scrape that foot, and they should both be down going. If one is up going, that's abnormal. If they're both up going, that's abnormal. If one is down and the other is mute, there's no, it doesn't go down or up, then that requires further, more detailed neurological exam. The next test we'll look at is the distracted straight leg raise. And as I lift up Lee's leg to test the Babinski's response, I'm also testing his sciatic nerve. This is an irritative test to see if any of the lumbar nerve roots are under tension from a lumbar disc herniation. And so this would be the equivalent of, if I can get you to lay on your back for me. So when you do the supine straight leg raise test, that is the equivalent of, if I have him, that's the equivalent. So that's a distracted. So if in sitting, I lift his leg up, so that's, turn this way a bit, that's 90 degrees right there. That's 90 degrees. And if he complains of no back pain, no leg pain, and I put him in supine, this leg has to be bent up to mimic the sitting. And if he stops me here and complains of back or leg pain, that's a discrepancy because we just did the test in sitting and he was 90 degrees here. He may be complaining of, let's say, back pain at 30 degrees, and that's a discrepancy, and that's indicative of a heightened pain response, or he's fearful of pain, or whatever the reason. I'll get you to sit up for me, please. Okay, the other thing we'll test is sensory testing, and this is a testing area for L5 between the big toe and the next toe. S1 is the lateral border of the foot, and L4 is the medial border of the foot up into the ankle, or into the medial malleolus. Now, normally if you have radiculopathy, it only affects one lumbar nerve root, and only one of these dermatomes will there be numbness, tingling, or dysesthesia. If you're doing sensory nerve testing and they complain of numbness and tingling in a stocking type distribution, so it's numb, the front, the side, the whole foot, the bottom, it's like they have a stocking on their foot, that's a Waddell's sign for sensory disturbance. There's no neuroanatomical reason for that. Only in rare cases like diabetic neuropathy or MS would a patient have something like that. And if they had those problems, they would be apparent. The next portion of the physical exam that we'll run through is tests done in the supine position. And we'll start with clonus, which is a pathological reflex. Again, we're looking for, or screening for, problems that could be in the spinal cord or the brain, and if these are present, then that would be a red flag, and that constitutes further workup. So what I'll do is I'll put my hand on the patient's bottom of their forefoot, and I'm just going to quickly jerk up like that, and there's a normal response in Lee here. And he'll just simulate for me that if I flick it up like that and it pushes up and down quickly, so it'll do this, it'll quickly vibrate up and down in my hand like that. That's a positive finding for clonus. And again, you're looking for a symmetrical response. So there should be no clonus in either foot. If there's 2 or 3 beats in each foot and it's symmetrical, and their neurological exam is normal otherwise, then that's an irrelevant finding, and you don't have to worry about that. The next test is the supine straight leg raise, and I'll bend Lee's leg up, which allows a little more movement at the pelvis, and it's also more in keeping with the tests when we do it in sitting, which we discussed earlier. And what I'll do is I'll lift his leg up, and what I'm looking for is reproduction. If the patient is complaining of leg dominant pain, I'm looking for reproduction of their typical leg dominant pain. So you can only have a positive straight leg raise if, while you're lifting their leg, they complain of leg dominant pain, their reproduction of their typical leg dominant pain. If I'm lifting up his leg and he complains of back pain, that is not a positive straight leg raise. So I'll check one side, keep that leg bent, and I'll check the other side. And a positive straight leg raise can occur down low at 20, 30, 40 degrees, and it can also happen up higher. Now typically what happens is the more acute or the hotter the nerve root, the lower the straight leg raise. As they get better, their straight leg raise will improve over time. Now sometimes you'll have a straight leg raise, you'll reproduce the patient's leg pain at a fairly high degree. In young flexible females, you may be able to get their leg all the way up to 100, 110, 120 degrees. And again, you're looking for symmetrical results. So if on one leg they get to 100 degrees and complain of leg dominant pain, their typical leg dominant pain, and you lift the other leg and it goes to 120 and there's no complaint of pain, then that's still a positive straight leg raise. So the next test we'll discuss is the well leg lift. And so if Lee is complaining of left leg dominant pain, so he has sciatica in the left leg, when I lift his left leg, that'll reproduce left leg pain. If I go to his unaffected leg, if I lift his well leg and that causes him pain, his typical sciatic pain in his left leg, that's called a positive well leg lift. I'm lifting his leg, the leg that doesn't hurt, and it's causing his typical sciatic pain in the other leg. And that's indicative of a large disc herniation, and it's a prognostic indicator that these clients or these patients will not do that well, and it's an indicator for more rapid referral to the surgeon and for diagnostic imaging. The next test we'll discuss is the crossover test, and if Lee, I'll get you to bend this leg up, if Lee is complaining of sciatic pain in the left leg, he's complaining of leg dominant pain in his left leg, and I lift that up, and that reproduces his typical left leg pain, and as I'm lifting it up, if that causes pain in his left leg, and as well it starts to cause pain into his right leg, that's called a crossover sign. So I'm lifting his affected left leg, it gives him pain in his left leg, but that pain crosses over to and into his right leg. And that's a very serious sign, and that's indicative of a massive central disc herniation. And these patients typically don't do that well, and again, they should be considered for urgent surgical consultation. It's a rare sign, but if you do see it, you should consider rapid referral. The next test that we'll look at is the double straight leg raise. And when I do the single straight leg raise test, I have this leg up, and that allows this leg to come up to 80 or 90 degrees. When I do the double straight leg raise, typically what happens is because both legs can move and the pelvis can rotate, I can get higher. I can typically get about 30 degrees higher, and that's what you should see. Now, if there's a discrepancy, typically what happens is I'll say to Lee, I'm going to lift your leg, and if he complains of back pain at 70 degrees, and then I tell him I'm going to do a double straight leg raise, patients typically equate this with being doubly hard, and if they have a heightened perception of pain or they're fearful of their back pain, they'll stop me sooner. And so if their single straight leg raise was 70 degrees, he may stop me at 30 degrees and say, oh, my back's too sore. And that's a discrepancy because, again, the double straight leg raise should be 30 degrees higher than the single straight leg raise. And so if you have that kind of discrepancy, that's indicative of a heightened pain response or fear of pain or some such thing. The last test we'll look at is the distracted straight leg raise. We covered that in the seated tests, but we'll review it here again quickly in the supine test position. So I'll put Lee's leg up like that, the other one flat, and what I'm going to do is I'm going to lift his leg up. And typically, if people are fearful of their back pain, they'll stop me down here at 30 or 40, 50 degrees and complain of back pain or leg pain. Now, if I have him sit up, this test, the patients don't realize it, but that's the same test as if he was in the sitting position. So again, those should be fairly similar. If there's a marked difference between the two, then that would be considered a discrepancy for whatever reason: fear of pain, anticipation of pain, increased pain perception. The next portion of the physical exam that we'll run through is tests done in the prone position. And the first test we'll do is a test of saddle sensation, and this is an extremely important test. And if a client on history is complaining of numbness in the saddle area, so the area in and around the genitals and anus, it's important to follow that up with the physical test for testing sensation. And in order to do this test, you don't have to disrobe the patient. All you have to do is move their pants down a bit, and you're just looking for the natal cleft. So right up high in between the cheeks, and we're just going to stroke like that. Can you feel that? Yeah. So right there, you've tested saddle sensation, and you've eliminated any consideration regarding bowel and bladder dysfunction. Yeah, and if they do complain of numbness in the saddle distribution, then that requires urgent surgical consultation. That's a red flag. The next test is another irritative test, and it's the femoral nerve stretch test. And typically, this is done by bending the knee. And that quite often results in the patient complaining of tightness or pain in the rectus femoris, which is a muscle, it's part of the quadriceps, runs from the anterior superior iliac spine into the top of the knee. The proper way to do the femoral nerve stretch test is to tell the patient you're going to put a hand under their thigh and you're going to lift their leg, and you lift the whole leg straight up. It's the reverse of the straight leg raise test. And if they complain of anterior thigh pain, which is their typical leg pain that they're complaining of, that's considered a positive femoral nerve stretch test. The next test we'll look at is gluteal muscle contraction strength, and this is a test for S1 muscle strength, and this is an optional test. And what I'll ask the patient to do is to squeeze their cheeks together and relax. And then what I can do is I can put my fingers right in the prominence of their buttocks and squeeze again, and you can feel the muscle contracting and your fingers will rise up. And what I'll get him to do, this is a very sensitive test, he'll contract repeatedly 10 times, and what happens is if there's nerve root impingement, you'll see the one cheek is going up but the other one isn't. And this is a test that patients typically aren't familiar with, and it'll give you a quite valid answer, and you'll feel either that the one cheek cannot contract, or that over time as they repetitively contract, it gets weaker and softer as you go along. And that would be indicative of weakness at the S1 myotome. The next test we'll look at is Pheasant's test, and this is a test regarding foraminal stenosis. And what I'll do is, can you just slide down the table here? A little more. I'll check the ankle jerk reflexes and just pull up your foot. I can check the L5. So I'm checking the L5 in the S1 myotomes. And then what I'll do is I'm going to lift his leg up like this. And I'm putting his lumbar spine into extension. I'm closing the neural foramina. And if they're stenotic, they'll impinge on the nerve root. And I will hold this for 90 seconds, which is a long time for the patients. They quite often complain of back pain. But what we're looking for is reproducing their typical symptoms. They may complain of dysesthesia or numbness or a woolly feeling in the leg, sometimes some pain. And after I've held this for 90 seconds, I'll put their leg back down and I'll recheck the neurological exam, and if there's a change in the reflex, if it dampens or if it's absent or their motor power is changed, then that's considered a positive response. Okay, on palpatory exam, a standard exam, I'll check the SI joints and up into the lumbar spine, and quite often the patient will complain of localized tenderness at one or two of the segments in the lumbar spine. And it takes approximately 4 kilos of pressure to blanch your fingernail bed. So if you want to be consistent on your palpatory exam, if you just press down until your fingernail beds turn a bit white, then you know that you're consistently testing in the same way. Now, superficial tenderness or tenderness with light cutaneous touch, if I'm just superficially or just lightly touching his skin, and the client complains of pronounced pain, then that's indicative of a heightened pain response, fear of pain, or some such thing. It's a Waddell's finding. The next finding we'll look at is non-anatomical tenderness. This is a Waddell's sign, and again, it's indicative of a heightened pain response or fear of pain. And typically, back pain will confine itself to a particular joint or a number of joints in the back. If I have a client or a patient with non-anatomic tenderness, they'll have pain out into the flanks. And so while they may complain of back pain, as I get further away from the spine, especially out into the flanks, if they're still complaining of pain, especially if I gently pinch the flanks very gently, and they're complaining of that reproducing their typical back pain, that is a Waddell's sign for non-anatomic tenderness. The next test we'll look at is the sloppy push-up or the prone extension, and this is a test to see if this reduces or increases their typical pain. And what I'll have is the client, I'll have them put their hands out in front of them. I'll ask them to relax, and what I want them to do is do the pushing with their arms. They can leave their hips on the table, and I'll just have them, so push up for me. There you go, and back down. And I'll get them to do that repetitively. Push up again, and back down. So it's important to remember that their hips stay on the bed, and that they do all the pushing with their arms. They're not trying to actively use their back muscles. Their arm muscles do all the work. Push up again for me. And you can leave a hand on these muscles just to make sure that they're doing it passively. Okay, and back down. And you would have them do that 5 times, or 10 if you like. And you're asking them if that reproduces their typical pain or reduces it. What you're looking for is reduction or centralization of their symptoms. So that would mean that if they're complaining of pain in this area, their area of pain shrinks up and becomes smaller, or their level of pain drops or reduces. The other thing that could happen is the opposite, where their area of pain actually spreads out, or it peripheralizes and it starts to travel out away from its origin. So when the pain starts to expand or starts to travel, let's say, into the buttock, that's worsening their pain. If they have pain in their buttock or in their back and that area of pain starts to shrink up or their level of pain reduces, that's reducing their symptoms, and that's a positive response.